Good morning, everybody. My name is Eric Yen. I'm the Director of Marketing for Shield Healthcare. Welcome to our webinar titled Practical Tips for Medication Management. A couple of housekeeping items. Attendees will be in a listen-only mode. If you have a question, please type it on the Q&A box. You can reach that tab on the bottom left side of your screen. If you have a question, you can type it in there. There will be no video portion to this webinar. It's only audio and the PowerPoint. At the end of the presentation, I will show you how to get the CE credits, but that won't be until the end. So we'll go ahead and get started on our webinar, Practical Tips for Medication Management. Your speaker today is Judy Adams. Ms. Adams is the President and CEO at Adams Home Care Consulting, where she provides education and consulting services to home health agencies, hospice associations, and health systems with a focus on operations, education, and compliance. Since 2012, she has traveled the East Coast of the U.S. extensively, leading courses on best practices for ICD-10 with an emphasis on team building strategies. At this time, I'd like to pass the presentation over to Judy.
Thank you very much, Eric, and good morning to all of you on the West Coast. I'm over on the East Coast, so for me it's just about midday. Glad to have you with us. So as we talk about this program today, medication management is really a key issue, especially in the home health field, where we have a lot of concerns about people going back to the hospital and other complications. So this program really has got three parts to it, so to speak. A brief overview of some of the projects that have reduced negative consequences from improper medication management. I'm going to talk a little bit about the accurate scoring of the OASIS items tied to medication management. Not to spend a lot of time with that, but they are key to how we're looking at the information. And then, of course, to identify tools available to improve our medication management skills. So why is medication management important at all? Well, I don't think there's any surprise in any of this to us. Home health value-based purchasing, star ratings, home health compare, home health caps, the Impact Act of 2014 have all targeted aspects of medication management as key outcomes as part of their quality initiatives. And this will continue with probably even more focus within the Impact Act that will have more aspects on transition of care, and I know we'll have more on medication management with that as well. The Joint Commission of Healthcare views medication management as a significant safety issue in all healthcare settings, and then we also look at medication-related issues are a leading cause of hospitalization for all patients, but particularly for older patients. And home health clinicians have the very unique advantage of being able to see all of a patient's medications in their home and may be the one setting that can best identify potential clinically significant issues involving the medication a patient is taking. All other settings, the patient would either have to bring a list or bring their meds with them. And of course, we know that from being in home care, we see a lot of things sometimes that either people don't think of as medications or they don't remember to bring. So if we look a little bit at some of the facts related to prescription drugs, medicated-related problems are common, they're costly, and they're often preventable in older adults. In fact, in general, it's expected that all medication issues are potentially avoidable events, so that if we were good in all of the stuff that we had and everything worked as it was supposed to, then we wouldn't have medication issues. Half of the 20 most commonly prescribed medications taken by older adults can raise the risk of falls. So that's another concern because falls also are very critical for older population. And in the U.S., about a third of seniors take 8 or more medications daily. So public, the payers, regulators are increasingly demanding action to reduce medication error. If you look at the cost has been estimated back in a 2013 study. It's a little bit further back right now, but it's definitely not gone down. The United States spends about 10% of our country's $2.7 trillion healthcare bill on medications. So it's a very significant issue. And then compounding with this is the issue that in the United States, there are more than 40 million people over 65 years of age, and fully one-third of them take that 8 or more medications daily. So lots of reasons why medications are a big concern and what's going on. If we look at some of the medication adherence issues, in 2007, the World Health Organization projected probably only 50% of patients typically take medications as prescribed. They updated the study in 2009 and basically found the same thing. So in terms of looking at what we had, non-adherence with medications was $290 billion in 2009. 37% of patients did not finish medications, 31% skipped doses, and they may skip doses for a number of reasons, of course, both forgetting to take medications or having cognitive issues, which causes them to forget to take some of their doses of meds. But also many people decrease the dose of meds that they take and don't take all of the times because of cost. And there's certainly a big cost associated with medications. And then 23% did not fill prescriptions. Again, in that area, we see a number of reasons for that. The number one reason is that patients may not have the financial resources to be able to fill all their medications. But another very high reason is that the side effects of medications are such that the patient is not willing to deal with the side effects and just forgoes taking the medication instead and just doesn't get it filled. If we look at some of the reported statistics related to medication issues, roughly about $100 billion per year, and estimates of the share of hospital admissions related to non-adherence. They're as high as 10%. And that was in 2012. Approximately 1.5 million preventable adverse drug events occur annually, resulting in 7,000 deaths per year are related to medication use. And adverse drug events account for an estimated 2.5% of emergency room visits for unintended injuries. So when you look at all of the factors of what happens as a result, it's pretty clear that medication use and adherence is a key concern in all of healthcare, but particularly for those of us who work in the community. And we need to make sure that we have tuned up our medication review and our education processes to ensure that patients are taking the correct medications at the correct dosage and frequency and are knowledgeable about the effects and untoward effects of their medications. So in order to kind of show the effect we've had when we are successful in looking at, from the community-based, looking at good processes for medication management, let's do a little brief review of some projects that demonstrate positive impact on medication management. There are really a number of these projects that have been done over the years, and they all show that the community-based services or folks working within the community can have a significant impact on what happens. In 2011, there was a project done by the ANA reported that was community-based care coordinators by Atherley and Thorpe and involved patients 65 years of age and older that were living in the community. And it demonstrated significant cost reductions among high-cost, chronically ill Medicare patients using nursing care coordination to educate and empower patients. So this was from June 2012 and was a very important program in terms of showing how much we can make a difference by using some nurse coordination. Laughlin and Bissell did a study in 2010 that described telephone outreach, which used an RN care coordinator. And the activity of that care coordinator, most activities were medication management, 89%, self-referral to primary care providers, which is educating people about when to go to their doctor or when to report information, and 51% was like care coordination among providers of services. So we see medication management, self-referral, care coordination time and time again as the key pieces in being able to minimize the negative aspects of medications. The findings suggested patients were frequently discharged from hospitals without medication knowledge or without financial access to medications. And so this began some of the studies on the transitions, particularly from acute care out to the community. But we have some of the same issues when we're transitioning between post-acute care settings as well. So a lot of this is a big issue. And most of these calls, this study in 2010 was really based on the use of 3 phone calls within a 24 to 72 hours after hospitalization that made some significant changes. So it doesn't mean a lot of costs necessarily. In 2015, there was a summary of a doctorate of nursing program. It was a capstone project by Diane Davis in 2015, and she studied the literature that was out there on medication management and actually wrote up about 14 of 36 articles that were out and summarized the key findings from that. So what she found were problems related to medication management consistently included incomplete documentation of prescribed medications. Now, that could be certainly by care providers, everything from physicians to home health agencies to anyone else who's seeing a patient in the community or at any other setting. There was also incomplete orders. Incomplete orders was a problem mainly from physicians, obviously, where it wasn't really clear about the dosage or how often a medication should be taken. And there's been several things done to try to help clear up the accuracy of orders. Inconsistent documentation of medications patients were taking, especially when there's a number of providers involved in the patient's care. So in this day of specialization, when people are being seen by multiple specialty physicians, they all may be prescribing medications, but who is it that may be getting that one comprehensive listing of meds that a patient is taking from all different types of providers? That's where home health comes in particularly strong in being able to see that. There's also non-adherence to prescription medications, and a few years ago we actually had some new diagnosis codes entered to be able to help identify what were those non-adherence problems, because non-adherence doesn't necessarily just mean the patient is not taking their meds properly because they want to take them improperly. It can mean there are reasons that they cannot do it. Either there's not a caregiver to help them, there's not funds, all of those things that are out there, and we can now track some of that on their diagnoses as well. And then incorrect dosages of prescription meds. So easy to get an incorrect transcription when a prescription is being filled or something along that line that might happen. Easy to see in the writing where twice a day could be interpreted differently, or the use of abbreviations is a problem. So we have a number of those kinds of things going on. If we look at this next slide, we're talking about Ellen Becker, Fraser, and Verney, who did this is an older 2004 collected self-report data, but this was specifically one on home health nurses. So they talked to 101 home health nurses about their clients' home medication schedule. Over this period of time, they looked at 1,467 charts. And what they saw was 78% of the patients were taking 5 or more medications. 21% of the patients reported to the home health nurse they didn't understand about how to take their medications after discharge from the hospital. Sometimes we do assume that people know or understand the directions, but often a lot of the directions are given on your way out of the hospital, which is probably the worst possible time to get any kind of instructions and to have a good rate of understanding of what those instructions were for patients going home. They're more interested in that point at going out of the hospital, getting home, looking forward to going home, juggling lots of things. And so a lot of the teaching that's done on discharge teaching, if it's done just at discharge, really does not have good response. We also looked at a retrospective study by Faust, Naylor, Bixby, and Radcliffe. That was a 2012 study, and it recommended some things about this whole issue on following up with patients at discharge. This particular study did look specifically at older adults with heart failure who were discharged from the hospital to home, and they recommended that patient discharge instructions and hospital discharge records need to be reconciled prior to the patient's discharge. that just having a list that is going home with the patient and not really looking at how to reconcile that medication with what's at home was really, really key. Now, the logistics to that can be difficult. Then they also recommended providing clear, concise patient teaching about medications and instructions at the time of discharge. The problem with the time of discharge, as I've just said, has to do with the fact the patient's focusing on going home, and it's difficult to get all that information understandable and for the patient to retain it. Utilizing home health nurses for additional post-discharge support and teaching, as well as medication reconciliation in the home environment, was the third primary recommendation. And that is a key one, and a key role of home health in the community is to be able to do follow-up on medications and help patients. If we looked at the McDonald and Peterson study of 2008, it pointed out the importance of medication reconciliation and improving medication management, specifically in the older population, with home health services. So these were some samples of some that did impact home health. And you can see we've been looking at this for quite some number of years now. The Visiting Nurse Association of America developed a curricula for home care advances in management and practice. It's called the VNA CHAMP program. It was developed to translate evidence to practice, and it has a focus specifically on for home health nurses and therapy managers, and includes topics like mastering medication assessment, reconciliation, monitoring for compliance, and improving patients' adherence. So right down to the basic issues of what we need to do with for patients at home. Setter, Corbett, and Newmiller in 2012 described the role of the home health care nurse with patient care during transitions and the importance of medication reconciliation and the medication management, and it showed medication reconciliation and teaching, if done consistently with each transition of care for every patient at every time they change from one level of care to another or one site or setting of care to another, and the communicated that reconciliation was communicated with the patient and among the healthcare team. There was definite support for decreased medication discrepancies, improved patient adherence, decreased potential of adverse events, and lower probability of rehospitalization. So this focused on nurses mainly and therapists. However, everybody should be included. Actually, this one focused mainly on nurses, but therapists also should be considered because they have a big role in this area, particularly in these days when we have a lot of therapy-only cases. Now, they certainly can still work in conjunction with nurses, but it's really important. And we do know that that whole medication reconciliation and teaching is tied into preventing hospitalizations within 30 days of discharge as a major focus in outcomes for both Home Health Compare, Home Health Compare STAR and Impact Act. So we're looking at all of those issues, and not just while we're still in with the patient, but once the patient is discharged and not on home health. This is a little bit of a very brief review of a reconciliation program model done by the Concord Regional Visiting Nurse Association. It's a home medication reconciliation program. Patients that were focused were age 65 or older, who were high risk, chronically complex, and comorbid disease processes. They had multiple medications, and they had a recent hospital admission, and they're very challenging to manage due to the complex diseases and social factors, and also they may lack a support system. So looking at this group of folks, we see a very high-risk population. This project was originally targeted in 2012, and with discharges from one medical center at a focused trial for home medication reconciliation, and they were looking at a small identified population. In 2014, they expanded to more nurses, involved more primary care practices in surrounding communities that were involved with the VNA program in that area. And what they found was there was a lot of measurable points in this data. Certainly they found out that home health medication reconciliation completed with the discharge list and meds in the home was effective. that patients' readiness for change and ability to self-manage medications is particularly good at home. The assessment of health literacy and teach back were very important to self-manage medications, and completing that assessment as to where the patient's at was key in setting up a program. Discharge instructions and medication list available, legible, and easy to understand. Sometimes it's in that three-part NCR type copy, and the copy the patient gets is really not very legible. So it really doesn't serve much use in that particular instance. Barriers to care, including financial issues, were identified. Any needed community resources or services were put in place, and follow-up with a primary care provider was scheduled. So this particular study looked at the issues and then also looked at how to address some of those issues. What they found were there were issues identified at the patient, the provider, and the system level. So if we look at the patient-level issues that were included, it was intentional non-adherence, where the patient chooses not to take the medication as prescribed or not to take it at all. Unintentional non-adherence, which is primarily those folks that have cognitive issues or are not able to access their medications. So it wasn't an intentional issue, but circumstances. The lack of knowledge or of the reason for prescribed medications, which makes you less likely to want to continue to take something that you're not sure why you're taking it. Sight or dexterity limitations, cognitive impairments, adverse drug reactions or side effects, and then financial barriers. And of course, with our elder population in the community, the presence of all the comorbid conditions actually complicates the situation. At the provider level, issues were mainly the illegible or confusing discharge or medication instructions. The prescribing medications are considered inappropriate for older adults. There is a list that's been done of that, and vast majority of meds, there's a large number of meds that are not appropriate for older adults. The number of medications prescribed, the more medications, the more chance that you're going to have problems and difficulties with meds. And duplicate medication orders with differing dosage instructions. Not only differing dosage instructions, but because of the use of generic and the use of actual names for drugs, we find complications there in terms of duplications as well. And then at the system level, issues included incomplete discharge instructions or the medication list, conflicting information from different providers across the system. We saw like primary care cardiologist and the orthopedist. We also see that certain specialists don't want to deal with issues related to meds for other conditions the patient has that are not in their own specialty. That's a complication too. We also saw a lack of appropriate services and places for return to the community, and different sources of information from different providers. So what kind of information are they getting, and is it conflicting or consistent? Unfortunately, too often it's conflicting. So if we took the top two or three from each of these settings, at the patient level, the top three are the number of medication errors, medications not on the discharge list, or duplicate medications listed. That was the number one. Number two was the number of patients who did not have all their medications in the home. So you can't be very compliant if you don't have it. And unintentional non-adherence. The patient did not understand how to take their medication correctly or was not given the correct dosing instructions. At the provider level, the top two were discrepancies between the medication list at discharge and the primary care provider's medication list on record, and illegible or confusing discharge instructions or medication instructions. It's one thing to talk about one medication and tell a patient how to take it, but the more medications and the more complex both the meds and the instructions, it gets very complicated. At the structural level, the top two issues were discharge instructions or medication list incomplete or unavailable. You notice that was at the top of every single level. So that whole focus on medication list is very key. And the second highest issue on structural was patients did not have new prescriptions after discharge. You can't be compliant with that which you don't have. So there was all of these issues. that all bring us to the point that drug regimen review is a major issue in home health. It's actually a major issue in all healthcare settings, but in home health, it's really a particular issue. There are about 3,000 home health agencies that are inadequately tracked or reviewed new patients' meds in the period between January 2010 and July 2015. That's a huge percentage of agencies. We only have about a little bit under 5,000 agencies nationwide. So we're looking at 3/5 of those agencies who have had problems with inadequately tracking or reviewing medications. And this was between 2010 and 2015, and it was finding by the Kaiser Health News analysis of federal inspection records. So these issues are widespread for sure. So looking at the drug regimen review, in one example, as we look at the issues of drug regimen review, this was a report that was actually reported in 2015, and it was picked up in the regular news as well. So what we saw was a 66-year-old patient was erroneously given methotrexate rather than the diuretic metolazone following a hospitalization for their congestive heart failure. It happened in 2013, but as you know, a lot of these things don't get cleared or even seen until a lot later. The methotrexate caused the patient to have mouth and throat sores, bleeding from the nose and bowels, and ultimately destroyed her ability to create blood cells. So what happened was the patient died of multiple organ failure caused by the medication. What made this situation a bit worse was that despite the fact that the home health agency caring for this patient had sent multiple nurses to see this patient, there were more than one nurse that went to see the patient, but nobody picked up the error that was there. And the agency had been cited less than a year before for inadequately reviewing medications for 3 patients and had pledged to make improvements. Yet neither of the 2 agency nurses who visited at home stopped the patient from taking the wrong drug. So a pretty significant issue on this failure was the fact that we weren't doing a thorough medication review or picking up on the fact that this patient is on a med she should not be on. So that's kind of an example of what might happen with these. We also want to make sure, so you can see from the literature, from the studies, from the reports, we can see that medication issues are significant. They do lead to re-hospitalization, they lead to high costs, they lead to poor quality outcomes, and that we need to do something with it. Well, it all starts for us in home health with our OASIS C2. And we know that the OASIS C2 medication items were revised in effective January the 1st of 2017. Excuse me. These revisions were basically driven by the Impact Act of 2014 that went into effect this year. And as I said, I think we will see even more coming up in the future. So the first question, M2001, was just a slight revision from what we had in the past. It's looking at, did a complete drug regimen review identify potential clinically significant medication issues? A very key factor within this situation was that they dropped the option that you could say you did not do the review. And the reason they dropped it is it is a Medicare condition of participation. There's really no such thing as not doing this review. It's whether the review showed issues or it didn't show issues. If a patient is not taking any medications, then that would be a time you wouldn't have to do a review. You've already checked to see if they have any meds, and that's an NA now. So part of it is saying we cannot avoid doing these. We really need to do these reviews. If there is no information available, or items cannot be assessed, or elements are skipped, like some of the drug-to-drug interactions, or only some parts of the review are done, then the option for scoring this item is to put a dash in the item. Now, many of your software programs do not have that option, so many agencies have another spot that says there was not a review done, but that is not in the original OASIS question. So the original OASIS question left the dash for those situations where you don't have any information. But remember, all the instructions about the dash is that it's not expected that dashes would be used very often. They should be in rare circumstances, primarily in situations where there's an unexpected transfer or discharge, or the patient dies before an item can be collected. So they should be very minimum that we don't have a review done. A positive response, a yes on M2001, is a calculation of that yes means that I did do the review, and then it's also telling me that I do have some possible issues, and that is a required for calculation of the impact measure drug regimen review with follow-up for identified issues. Those would all be led to by the yes response in the question. So this whole review is very important to do with meds and to get information right. So that comprehensive drug review applies to all patients being seen by the agency, regardless of whether the OASIS specific requirements apply, because the comprehensive drug review is part of the conditions of participation. The other thing is that the documentation in the clinical record should clearly show medication review was done and education provided. And then whenever we're doing education provided, we should also be recording what the response is to that education. Can the patient or the caregiver tell us about their meds? Can they tell us accurately when to take them and how to take them and when to not take them? So we have that issue. And then documentation in the clinical and record should clearly show medication review and that education provided. It's got to be documented. We've got to document what we taught about, and also we need to be documenting how did the patient or caregiver receive it and how much did they retain of that information that we gave them. So we're going to be looking at that. So this comprehensive drug review is basically, it's got to include all medications the patient is currently using in order to identify any potential adverse effects or reactions. And that includes ineffective drug therapy, significant side effects, significant drug interactions, duplicative drug therapy, noncompliance with drug therapy, and all medications over the counter, such as herbs and oxygen and TPN the patient might be using. So everything that's going in for that patient, because they all have the potential of having interactions. So really what the drug regimen review process is a continuous cycle. We're assessing, reviewing the meds, reconciling the list, make sure it's the accurate one and the patient's taking them right. We're going to alert and notify the physician if there are any problems from doing the review. Then we're going to do follow-up with the patient and caregiver in terms of making sure they understand how to take that medication correctly. We'll follow up with the pharmacy if they've got information from the pharmacy waiting. We also go to implement education because we can't correct anything until we get to education. So we're identifying issues throughout the time a patient's on home health services. We're going to be educating, we're assessing and reviewing, and again around. Whether the patient actually goes into another hospitalization or just goes to the doctor's office or sees another doctor, you have to be looking at reconciling meds on an ongoing basis. So the patient's list of medications is reviewed and updated on an ongoing basis. While OASIS C2 only requires that comprehensive drug review at start of care, resumption of care, the fact is that we really need to look at the drug regimen review at each and every OASIS time point, and that's the best for practice. We also see that it includes assessment of the patient's knowledge and ability to take medications, and if we're doing it as follow-up for the patient, then when we go to see that patient next time, we need to let them know that they're due for drug regimen review or they've just had one or what's happened with that. So we do have those issues as well, and it needs to be an effective drug regimen review. So the review has to be part of every visit throughout care. It's not limited to just designated OASIS time periods. It's not limited to just individuals, like only the nurse can do it. Everybody on the team should be asking the patient on every single visit, do they have any medication that has been changed, a new amount, a new drug, a new type, anything at all since the last time they visited. If everybody asks that question on every visit, then the patient will be much more aware. Sometimes the issue is the question when you ask, is there a change in your medication? Folks don't understand that question. They think, oh, I'm still taking the medicine. The doctor didn't take me off any medicine or put me on anything. I might have gone and they might have changed my dosage, but they don't look at that as a change in medication. So there are other things. The other things are, too, that many times people don't think about over-the-counter drugs as being medications or as being drug treatment. And so they don't even think about, what do I take for a headache? What do I take if I have an upset stomach or if I have diarrhea or constipation as a change? So we have to be more specific about the kinds of questions that we ask. And it needs to happen on every single visit that we have. So that's really important throughout the episode of care, every visit, every staff member. And that is the number one activity to prevent medication issue. Constantly looking at the medications, constantly reviewing them, updating the information if the patient doesn't seem to be aware of what it is. Asking the patient if they've been to the emergency room since someone last saw them or since you last saw them. If you say someone, then they may always think it's somebody else, but that information doesn't get back to that someone else. So if we put it in the personal, since I last saw you, have you gone to the emergency room? Have you gone to see the doctor? Have you had any medicine stopped or new medication given to you or a change in the dosage? And you want to check the medication bottles against the list to see if they're right. So if we look at clinically significant medication issues, they can include adverse drug reactions, ineffective drug therapy, side effects, drug interactions or drug-food interactions, duplicative therapy, omissions. So I just didn't get it. I don't have it. Dosage errors on the high or the low end, gave a dose too high, gave a dose too low. Those particular ones, the dosage errors, have to be reported immediately and take whatever action is necessary. Non-adherence is the knowledge limitations as well as purposefully and accidentally not complying with the way meds are ordered. But if we know about it and we know what the cause is, we can actually make more impact on the patient than anything else. So we do have all of those issues to think about. So clinically significant medication issues certainly can include, if we look at clinically significant issue, it's just an issue that in the care provider's clinical judgment requires physician or physician designee notification by midnight of the next calendar day at the latest, that there is some kind of change. That change may be very significant. It may not be. It may be appropriate, like in your case. We could have a patient who's on a over-the-counter medication and they shouldn't be using it, and we have to have that information. So potential and existing clinical significant medication issues as well as actual ones. Is there something here that might happen because of two meds that they have? And any circumstance that does not require this immediate attention is not considered a potential or actual clinical significant medication. So it's really a clinical decision. Every visit, every staff member looking at all the meds, and then notifying the physician if we have a clinically significant. Is it something that should be reported? Is there a question about it? Are we not sure what the meaning is? And that's what we want to have in those questions. So if we look at our medication reconciliation, it's a process of creating the most accurate list possible of all medications a patient is taking. That would be the drug name, dosage, frequency, and route of administration, and comparing that list against a physician's admission, transfer, and or discharge order. And comparison ensures that the patient is taking the correct medication at all transition points in care, or anytime a comprehensive assessment is done, or even just randomly making sure that it's together. So that's when we're going to be taking those, doing those reconciliations. If we look at reconciliation, though, it is not done by asking questions to the patient. It's actually done by looking at the list and looking at the bottles of medicines they have in the home. Often, if you ask the question, you get a no, there's no change. But you look at the bottles of medications and you can see the dosage error written differently. I can't change the dosage unless I have an order. So I need to be looking. If I see a bottle that has one dosage and the patient's taking another, then there should be documentation of why that happened. Maybe a communication note to the physician to clarify, or something in the record that shows it was changed. Medication reconciliation is critical to providing safe patient care across all spectrums of care. And all healthcare providers and settings must support efforts to achieve accurate medication reconciliation. So we really need to get that information and to make sure it's accurate and the patient is taking what they're supposed to. Further importance, issues that were related to medication reconciliation. One, again, patient's lack of knowledge of medications, especially at the transition time points. Maybe somebody told them in the hospital, but they don't remember when they get home. A lack of standardized location of medication information in the medical records. If we all know where to look for the information, we can add to it easier or see if there are side effects from it at any point. And then we have the lack of integration of patient health records across the continuum. Well, what happens there? Well, maybe the hospital uses one record with one software system and the home health agency uses another record or another form of the medication. So we've got to look at all of that. So involvement of numerous specialty physicians, all those things are risk factors, but if we do the medication reconciliation, we're going to pick up on those and things that are different. So the label on the bottle of the prescription med constitutes a physician's transcribed or documentation of the order. We know from our own experience that you go to the doctor and you end up sometimes having a change. The medication is changed. They don't get you another whole full bottle of a new prescription. They just either tell you what to make a change of on the medication, or they may phone it into the pharmacist who then updates the record in the pharmacy and calls to tell you what to do. But it is a change when you have something that the bottle says one thing and you're supposed to take something else. This information can be noted in the patient's clinical record as well and listed on the physician plan of care. So when the patient is receiving therapy-only services, collaboration between the therapist and nursing staff is allowed to complete the drug regimen review, but it's also, therapists can also do a lot of this review. I know it varies depending on somewhat on state regulations and also on when the therapist was trained. But some of the best people I've seen personally when I've done record reviews are in fact therapists. So it's within the scope of their practice. And if you're looking for more of that information to support it, look at the practice acts for OT, PT, and speech language pathology. And you see they all support the fact that the therapist, it's within their scope of practice to collect information about medications, to actually provide information unless the state law is different. So definitely therapists can do this. And the other thing is, working as a team in our agency, you can always ask for a referral for nursing when the patient is telling you they don't understand many of their meds, or you go out there and there's a whole bunch of meds around, or it seems like there's several prescriptions of the same medications that are there. You know, the therapist doesn't have to do it on their own. They could call the physician and ask for a therapist, ask for a nurse to come out on a consult. So if we look at some of the review responses, a situation where the clinician may determine that a potentially clinically significant issue exists could be you look at the patient's list of meds from the inpatient facilities. It does not match the medication list between your assessment and what was the list that came from the facility. That's automatically a reportable change. They don't list together. They don't match. Assessment shows that the diagnosis symptoms for which the patient is taking meds are not adequately controlled. Well, then they're not adequate medications. Patient seems confused about when and how to take medications, indicating a high risk for medication errors. These are all indications that there is clinically, potentially clinical issues. Other ones that could be potential clinically significant issues are based on clinical judgment. The patient has not obtained their medications or indicates that they will not be obtaining them. Well, that's going to be a problem because it's not going to match up with the list that they have. Because of financial access, cultural, or other issues with medications is usually the reason that they haven't obtained the meds. Finding that out is also helpful. If a patient has signs and symptoms that could be adverse reactions from a medication, then that needs to be reported, and that is clinically significant. If a patient has multiple non-prescription medications, over-the-counter drugs, herbal remedies that could interact with prescribed medications, they should be reported. So for each patient, there should be a care coordinator, a case manager, a supervisor, a clinician who's responsible for that patient. And if other clinicians are seeing the patient as well, they can contribute information into that person coordinating care to make sure that it's in the record. And those patients that have complex medical plans, medications prescribed by multiple physicians or obtained from multiple pharmacies, makes that risk of drug interaction so much higher. So, survey review topics related to drug regimen review. These are some of the issues that have come up from surveys. Agencies must have procedures in place that address how drug review is conducted for therapy-only cases. How is it going to be done? Are your therapists in your area allowed to do it by state law? Are they trained to be able to look at medications? And this is not actually a negative interaction with the medication. It's by each medication. Are we taking it the way we're supposed to? Is there any problems with the way it's listed? How drugs are reviewed when the medication occurs. Are modified or changes after the start of care assessment. So we got the start of care is the key part, and then we've got the other pieces too. And then what's the process for reconciliating medications when there are inconsistencies between the prescription bottles and the clinical record? Does it focus to one person to call the physician? Does each clinician call the physician to clarify? Are you using a discrepancy tool? I believe one of your extra handouts is a discrepancy tool where you can record the information, send it out on a fax to the patient, and that might be a way to get that taken care of. You can get a response back, and you have it all documented as well. The agency has to have procedures that address the criteria or resources used to identify potential adverse effects and drug interactions. Are you using a software program that's in your office or it's already built into your electronic records? Are you using a textbook that people are looking things up? Do you have somebody in the office that may be going through and reviewing medications so you can get that information back to the primary clinician seeing the patient? So what do you do if you find the patient is out of compliance with medications? Do you further evaluate that? Do you maybe get a social work consult in because maybe it is a cost factor and economic reasons? How does the agency respond to prescriptions from physicians other than the physician responsible for the patient's home health care? You've got your main physician who signs the plan of care. That physician probably does not want to countersign other physician orders, but if there are other physicians seeing the patient and ordering things, that still goes into the medication therapy for this patient and needs to be reviewed. And what actions does the agency require its personnel to take if your personnel identify a patient sensitivity or other medication problems? So there's a whole bunch of things that we can do in this area. In the medication follow-up at M2003, 2003 is the start of care, resumption of care. Did the agency contact a physician or physician designee by midnight of the next calendar day and complete any prescribed or recommended actions that were in response to that call within that same time frame? And it's a very simple question. You either did or you didn't. So yes or no. M2003, as I said, completed at start of care, resumption of care. If the qualified clinician determines the patient is experiencing problems with his or her meds or identifies any potential adverse effects or reactions, the physician must be alerted and respond with recommendations that are implemented by midnight the next day. Sometimes the physician isn't giving you anything specific on that particular patient, and so you still have to document that you've contacted the physician and what their decision is. They may say, just let it ride, or I'm not going to do anything about it, but you still need to document that you contacted the physician and they contacted you back and what their directions were. Recommended actions must occur within the following time frame for start of care. So allowed time frame, that's the within by midnight the next calendar day, because that's something you already have on order for the patient. So if it's something that's ordered for the patient, then I need to be doing it on a regular basis. So physician contact. Physician contact means contact with the actual physician or with the physician designee, and it can be made by telephone, voicemail, electronic means, by carrier pigeon if you have some training to go right to the doctor's office, as long as we know the message is given and received by the physician. The communication can be directly to and from the physician or by physician. So when we have our contact communications directly through the physician, they can be through their designee, they can be through their office staff, they can be on behalf of the physician. It's all in accordance with legal qualifications in your area that you can do those issues. And when we look at it, remember that physician notification alone is not medication reconciliation. To have medication follow-up and reconciliation requires two-way communication to the physician and from the physician regarding the potentially significant medication issue, and then also completion of any prescribed recommended action no later than 12 midnight of the next calendar day. That documentation of that communication is vitally important so that we know that it's there. So you can see on this slide those parts, and they have to be there for every time. Now, M2005 is the follow-up that we would do later at discharge transfer, and I have to see all that documentation because problems I had at the start of care, resumption of care, will also be reported again at the transfer discharge. So our response guidance is if the physician or physician designee recommends an action plan that takes longer than the midnight tomorrow night, as long as you complete everything that you can be done, that you can do and can be done through that time period, then you get a yes response. You have responded and you have followed all of the requirements. If that would be like a weekend on-call physician who's unfamiliar with a patient, directs the agency to do something on the immediate, whether the patient could continue the medicine over the weekend or not, but then says, and call the primary care physician on Monday for further orders. Well, Monday's going to be more than the next day by midnight, often if you were admitting on Friday or Saturday night, and as long as you did everything you could do. But do remember that when you have a patient who has a medication you're not sure whether to give over the weekend, you kind of need an immediate choice about what to do, and that could be from the covering physician, either hold it or to give the medication, and then get the ongoing stuff from the primary care physician. So we can do both. When multiple potential clinical significant medication issues are identified at start of care and resumption of care, all of them have to be communicated. All of them have to have some response and then some recommendation. The recommendation may be to do nothing. The recommendation may be, I see these two medications. You've called about a medication you think is potentially conflicting with another one, and they're saying, that's fine. It's been that way. I want it to be that way. The key piece then is documenting that you did have that communication. You got the return communication, and the physician is saying, okay, we're not going to do anything different. That's something they've been on for a while, and it's the best way they can be monitored. I think about that a lot when you think about Coumadin and aspirin. We know that normally we don't give patients Coumadin and aspirin. That's an automatic. It's going to flag up always as an interaction. But in some cases, that's the way you have to monitor, or that's the way you have to control a patient, maybe a baby aspirin and a lower dose of Coumadin, because if they try to do it just with the Coumadin, they get too out of control, and the aspirin alone doesn't do it. So if the physician's designee response to notification of a potentially significant issue is that there's no new orders or instruction, document that. You must document that physician responded and what they said so that it's clear. Otherwise, it's always staying out there as to what happened. You can't assume somebody did do that, did the follow-up. If we look at a potential clinical significant medication issue was identified, the clinician attempted to communicate with the physician but did not receive communication back from the physician or their designee until after midnight of the next day, then we cannot say yes, that we resolved it. We have to say no, that there was an issue, but we did not follow all of the time frames in order to be able to respond and get that response and resolution within that by midnight the next day. So here's an example from the M2003. During the start of care comprehensive assessment, the nurse completed a drug review, identifies the patient is taking 2 antihypertensive meds, one of which was newly prescribed during her hospital stay, and another that she's been taking prior to the hospitalization. During the home visit, the nurse is saying, well, I'm not sure if we're going to do 2 of these meds or not. Many people are on multiple antihypertensive medications. Is this correct or not? The patient wasn't sure as to whether they were supposed to take their other, but thought, well, they told me to take my regular meds. This is my regular meds. So during the home visit, the nurse contacts the physician's office and leaves a message with the office staff, providing notification of the potential duplicative drug therapy and requests for clarification. Well, nothing goes on that evening, so she doesn't hear anything the rest of that day or that evening, and the next day the nurse returns to the home to complete the comprehensive assessment, again contacts the physician from the patient's home. This time the physician's office nurse reports to the nurse that the physician would like the patient to continue with only the new prescribed antihypertensive and discontinue the previous medication. So based on this information, the nurse actually documents on her visit note that she got that information, and she educated the patient on discharging or discontinuing the medication taken prior to her hospitalization and on destroying that medication or storing it away from the current meds. As we know, many of our older patients do not like to destroy meds, so at least you need to get it instructed and the patient agrees to move it away from the current meds. So how would you respond to M2001 and M2003 for this patient? Well, at M2001, you did do a review and you did find issues. The nurse then on M2003 contacted the physician, and the physician did not call back that day, but when the nurse followed up the next morning, their physician's office person did have information. So we had that information, and the instruction was done by the nurse before midnight the next day. So everything was taken care of. So in this case, we did have a issue, but we also resolved it. So we had a yes that the communication occurred and it was resolved. At 2005, this is the medication intervention. Did the agency contact and complete the physician or physician designee prescribed information by midnight the next calendar day? And those, if you see, says since. It means that any issues that were identified at the time of or since the start of care, resumption of care. So anything that had happened on the last start of care, resumption of care, is also going to be captured again at the transfer and discharge. So, or a death at home, any of those. So it's each time as well. So we have to look at what happened then all through the time. And that's why if all the medication information is in the same place, so everybody knows where to look for it, if we document it the same way, if we have documentation clearly what the physician said, it's easy to answer this question. You may also want to look at a process in your agency as to how you can find this information clearly. Do you want it in the clinical note? Do you want to use some kind of a flow chart or a flow sheet in your record That'll be purely up to the agency about what you might have to be able to find this quickly. And then how did you find out that the physician was notified and they had a response? I can see a flow sheet helping a great deal with that, especially for a patient who's on service long term, where it could be many weeks and even months that you're going back since the last start of care or resumption of care. True, most of our patients are short-term, but we have a lot that are long-term as well. So at 2005, on that intervention, if multiple potential clinical significant medication issues were identified, again, all must have been communicated to the physician or their designee, completion of all the prescribed activities by midnight of the next calendar day in order to respond yes. So it's the same kind of response question as in 2003, but the time frame is different. The 2005 is a very long, or could be a very long time frame. So if we look at the intervention, you would enter no if any potential clinical significant medication was identified at the time of or since the start of care and was not both communicated and addressed in the time frame. So it could have been the one that was originally at the start of care, resumption of care, or it could have been any time since that time. Any one. So it's got to be 100% compliance to get a yes response that we did what we needed to do at 2005. Very important because we know that different people complete the transfer and discharge assessments than do the start of care and resumption of care. So it's really, really important that we get that information. Looking again at 2005, if the issue was identified at the most recent start of care resumption, it is reported again, not only at 2003 on the start of care resumption, but at transfer, discharge, or death on 2005. Kind of like double penalty in a way. Here's an example. During a discharge assessment visit, the nurse reviews the patient's medication list, confirms there's no potential clinically significant medication issues present. In reviewing the clinical record, there is documentation that a drug regimen review was conducted earlier in the episode with no potential clinically significant medication issues identified. There's no other documentation to indicate any other potential clinically significant medication issue occurred during the episode of care. So how would you answer 2005? This is your dream. This is what we want to see, and that would be it's NA. There were no issues, and I clearly can identify that because the record documented what happened at the start of care, resumption of care, what happened throughout the care, and that there was no issues in any of those times. So that would be a very good situation. Had there been documentation that a potentially clinically significant issue had occurred during the episode, and there was no documentation indicating follow-up with the physician by midnight of the next calendar day, then we would have to respond no or 0, that we did not meet this criteria. So the other two medication issues, just to look at this whole piece, M2010, which is patient caregiver high-risk drug education. That's the high risk that's done at start of care, resumption of care. Again, requires that we've identified what are the high-risk meds the patient's on, and that's identified by the agency in terms of categories or drugs or whatever you have. And then we're going to also indicate there was any education, the education was done in our record, and if I have both of those parts documented, I'm good to go, and I have a, has the patient received instruction, I have a yes. If I look at a 2010 scenario, Mr. Green had a history of hypertension, being admitted for management of COPD following discharge from the hospital. His hypertension is controlled now using a diuretic and low-salt diet. During the medication review, the clinician finds he's currently taking an antihypertensive that was discontinued before the discharge from the hospital. Well, we have an issue here, correct? So if we have this issue, I now know that this is antihypertensive is a high-risk drug, and the clinician has to validate with the physician that the drug should be discontinued and then instruct the patient not to take the drug. If I did all of those things, then I could answer that the patient was educated on their high-risk meds, and I also would have the correct follow-up when I get down to transfer, discharge, or death at home related to the 2005. So 2016 is patient caregiver drug education, and in looking at this one is during every episode, we have to make sure that all patients are instructed by agency staff or another healthcare provider to monitor the effectiveness of the drug therapy, adverse drug reactions, significant side effects, and how and when to report problems that may occur. So to answer this question is, was the patient instructed on all of those elements for every medication, over-the-counter, prescription, and prescription medications that they have? And if they have, the answer is yes, and I'm fine. I'm going to have good outcomes. And if the answer is no, I want to probably document in the record what were the circumstances. And certainly in order to be able to know that, I had to have seen documentation in the record where the education was given about all of the meds and all of the elements that are in this particular item. So looking at that guidance, it applies to, as I said, all prescription over-the-counter. It should support the interventions to educate the patient. If the interventions were not done, then we need to document why. Sometimes it could be something that we couldn't help, like the patient was transferred to a nursing home before we completed all that medication education. The item is used to calculate process measures to capture the agency's use of best practices following the comprehensive assessment. So again, documentation is key, as it is in everything in healthcare. The medication teaching tips. This goes along with trying to get our outcomes. So as we talk about this one, well, medication teaching begins at start of care visit. Ongoing medication review and education reminders provided at every visit support ongoing evaluation and understanding of meds. One of our HCAPS outcomes in home health is asking specifically if the patient received medication teaching. Well, we need to make sure the patient recognizes when we're doing that teaching. Just announcing at each visit that we're going in, today we're going to be talking about your medication, some of the uses of your medication, and then whatever medication it might be, your heart medication, your breathing medications, whatever. Using standardized teaching tools and providing written drug information to patients helps remind people not only what to do, but that they've had this information. Continuously evaluating and documenting the patient and caregiver's response by a teach-back method. Often that should be a little bit of delay. You can teach back on the same visit, but then the next visit or maybe the visit after that, it's good, again, to ask that patient, so what do you remember from our discussion about your heart medicine and when you were supposed to take it and what it's for, so that you can see on teach back whether they really understand or not. You may want to think about teaming up with local pharmacists or pharmacy education programs regarding options to simplify a patient's medication regimens, the number and dose of medications. The fact is, the more that we're out there, the more meds they have, the harder it is to be compliant with all the meds, no matter what the age. So to help with the HCAP scores, like I said, you want to give a statement like, let's talk about your medications very clearly when you are talking about the meds. And if everybody's doing this every visit, so you say, well, yeah, but who everybody? Because the nurse would be doing that. What about the therapist? Well, the therapist can ask. They can also ask, do you have questions about your medication? Tell me about why you're taking this, asking about a particular med, your heart med or your breathing med. Do you have any questions about any of your medicines? Have you gotten anything different in either the amount or the time you take it or a different prescription since I was here? Everybody makes it aware, and by everybody going into the home asking that awareness question, then the patient is very cognizant that they've had this review, and they're going to be more compliant with their meds. That actually even applies to aides. The aides cannot do teaching about medications, but they certainly can find out from the patient has anything changed and alert the nurse or the therapist who's supervising them, and then they can get that information across. Any medication teaching that is done by any staff member should be documented, and the drug regimen review, and when we do some reconciliation in between times, that can be documented as well. So what are some tools and strategies to improve? Well, we've already started talking about some. One is using a medication checklist to guide in asking about medications on the comprehensive assessment. As you walk through the house, As part of that assessment, ask the client to show you where medications are kept. While making visits, look for medication bottles. Frequently, they're on the kitchen table, they're on counters, they're next to the bed, they're next to the patient's favorite chair. As a matter of fact, surveyors say that's where they usually find meds, and they don't understand why home health staff has such a hard time keeping that list updated when they walk in and they clearly see it there. This is kind of that issue of familiarity. You sometimes don't see things. You go in and see this patient lots of times, you might not recognize as much that something looks different. Whereas a surveyor is going for the first time, they might, it kind of catches their attention more. But just making sure what's over there and just looking at it each time. If there's something that's lying on the table or by the bed that's a medication container, looking at it. You want to give the patient a list of medications to take to the doctor for any doctor visits. On each visit, ask if they've seen their doctor since your last visit. Even better, when you give that list to take to the doctor with the patient, you have on the bottom of that list, please call the home health agency if there are any changes made to this list, so that now you're also reminding the physician to call you. If you go the next day or the next visit after a doctor's visit, asking the patient, did you have any changes? Well, I think he changed something on my medicine, but I'm not really sure. Then call the physician and find out. If you can get the physicians to write on the sheet and make changes, that's even better, because then you have this kind of tracking device that comes back, and then you know there's been a change. I don't have to do those phone calls, which are difficult. So asking those questions, have you started taking anything new? Is it anything changed? Has the doctor made any changes to your blood pressure, your breathing meds since I was here last? Helping to identify by what they're used for is the easiest way for patients to identify what the meds are. So here's some examples of this medication checklist. This would be sort of walking through, asking some questions. Where do you keep your medications? Do you keep them in your bedside table, in the bathroom cabinet, in the kitchen cabinet, in your closet? Do you have any in the refrigerator? Do you have any things that are over the counter, things that you can get from the drugstore or from the Walmart or from the dollar store? What do you take if you have a headache, if you're constipated, if you can't have a bowel movement, if you have diarrhea, if you get a cold? If you ask about these, they're liable to tell you, but sometimes they don't think about it being new or being a medication. I just know I always take that medicine if something happens. Also, do you take any herbal remedies or vitamins? So you got yes and no questions, but it gives you the base to go forward. Some other things, do you take blood thinners? Do you take any medicine for chest pain? Do you take any type of medication by injection or by shots? Well, if yes, is it insulin? Do you take something else other than insulin? It might be B12. It might be something else. Are there any other medications other than the ones we've talked about? Do you use oxygen, and do you use it all the time or just as needed? Do you use inhalers or nebulizers? How about eardrops, eye drops, nose drops, creams or ointments? People don't always think about those as medications, but they are. What kinds of things do you use? So any of these things, if you get a yes to, you just follow it up. What kind? Why do you take it? How often do you take it? Do you have any medications in the home that you do not take? Oh, that's another helpful one, because sometimes there's meds there, but they don't take them anymore. Where do they keep the non-used medications? Trying to encourage people to discard it is good, and we all know it's difficult sometimes. Some other things on this one, did the hospital give you a discharge medication list? Did somebody, when you left the hospital, give you a piece of paper with a list of your medications? That's another important one. Do you have prescriptions that have not been filled yet? Well, that's a reasonable one to ask, because you decide if it's clinically significant or not. Could be a clinical decision. I go out on the afternoon, they come home from the hospital. They tell me that there are new prescriptions, and the daughter says, I'm going to fill them this afternoon, but we wanted to get mom settled first. Well, then there's a clear plan to get that done, and I would just do a phone follow-up maybe later that day or the next morning to see if that happened, and if it did, then you did not have an issue. If it did not happen, it is a clinically significant issue if the meds are not in the home. But if they've got a realistic plan and you can follow up on that, you can add to it and use that in your response. So what pharmacy do you use to get your medications? Do you ever use any other pharmacy? Does anyone help you take your medications? Does anyone have to help get your medications and bring them to you? Like if they're in the refrigerator, can you get to the refrigerator? Or if they're up on a shelf. If there are small children in the home, the medications may be stored up high and someone else has to get them and bring them to the patient, which means you're going to score with assistance. And do they fill a medication box or put medicines in containers? Does anybody do that for you? Do you do it for yourself? That makes a difference too. Would you like someone to do that? That may be something that we're going to add. Testing the ability to access medications is, can you show me how to open the medication bottles? Anybody knows that the child-proof ones are pretty accessible to children and pretty inaccessible to a lot of us who are adults. So we have to look at that. Where are the medications and how do you open the bottles and can you get into them? Have them actually show you if they can, how they open them. What about reading the label or following the directions? The directions may be different than on the label, or they may be written on the label. Can they verbalize directions? How do they take it? What does the bottle tell you and how do they take it? Can the patient tell you any other way they identify their medications if they can't read the label or the label is smudged or it doesn't work anymore? Some people use a series of elastic bands around the bottle to tell them how many times they have to take it. Some people use a capital letter on the top of the cap, and that helps them know which medication is which. There are many other ways as well, of course. Can you get to where your medications are stored? And how about, can you get water or other liquid to swallow your medication? It's one thing to get my meds, but what if I don't have anything to drink with it? How am I going to get it down? So we have those issues. The Beers criteria and potentially inappropriate medication inappropriate medication use in older adults is a great tool. It was developed by the pharmacy group, Safe Medical Medication, some years ago, and recently, beginning in 2012, the American Geriatric Society has kind of taken over to update this list more often. So these lists give potentially inappropriate medications that continue to be prescribed and used as first-line treatment for the most vulnerable of older adults, despite evidence of poor outcomes. That could alert you that maybe we need to talk to the physician and think about talking about whether we need to use that medication or something else. Criteria are divided into three categories: potentially inappropriate medication and classes to avoid in older adults, potential medications and classes to avoid in older adults with certain diseases and syndromes. So specific types of diseases and syndromes should not use certain drugs. And then medications to be used with caution in older adults. That was added beginning in 2012 with the expansion by the American Geriatric Society. They have a little list that you can get that are card size. They have small ones that you can carry with you. They do have larger versions, and if you look at the resource list, you'll see how to access the American Geriatric Society as well. So you can get those resources. So the AGS Beer criteria, it's shown that the number of medications have limited effectiveness in an older adult and are associated with serious problems such as delirium, gastrointestinal bleeding, falls, and fractures. In many instances, a safer non-pharmacological therapy could be substituted for the use of medications, and it could be a less, more than, rather than a more approach of giving medications. It's the best way to improve healthcare outcomes. So looking at options and alternatives, that may be another thing that helps as you're looking at dealing with patients. There's a lot of good research that was found by the AGS or the American Geriatric Society about the medications, also by the Institute of Safe Medical Practice. So updated criteria should be viewed as guidelines for identifying medications where their risk for older adults outweighs their benefits. Medications have a high risk of toxicity and adverse effects in older adults and sometimes limited effectiveness. There's a table 2, has medications that should be avoided in favor of alternative, safer medications. Now, you can't just go making these changes, obviously, on your own, but you can collaborate with the physician about making these changes. The drug disease or syndrome interactions summarized in Table 3 are particularly important in older adults who have multiple comorbidities and may have some of these common conditions. There's also a sample medication simplification protocol. Now, this protocol is to encourage a standardized and collaborative approach to simplifying complex medication regimen. If you've got to take medications every 2 hours throughout the day, it's going to be hard to keep up with it. If you can limit the number of times you have to take meds, if you can decrease the number of medications, if you can substitute a longer acting for a shorter acting medication, it really does simplify out how the meds are going. But not one size fits all for all patients. So again, in this situation, agency staff can work collaboratively with an organization, a community-based pharmacist, a physician, to apply the criteria and meet the goals. So it could be with the physician, it could be with the pharmacist, it could be a local pharmacist in your area, it could be with a school of pharmacy. So what we're trying to do in the medication simplification, encourage the use of a single pharmacy to enhance regimen review and collaboration with the pharmacist. Consider discontinuation and substitution of medications included on the Beers list. Consider opportunities to decrease administration frequency through the use of sustained release or long-acting products. Consider modifying administration time for medications with actions or side effects that interfere with ADLs or quality of life. Often we'll improve compliance with meds if we can decrease the side effects from the meds, and that often has to do with how we take them. So all of these simple medication simplification techniques work. They work well, and we can use a number of them. We can suggest them. Some of them we can just help the patient modify their system with. You can consider non-pharmacological approaches to certain things, certainly with pain, with some other issues, sleep or other, sleep meds are not great for elderly, so looking at other ways of relaxation and going to sleep. Consider reduction of multiple medications to treat a single condition, unless combination therapy is really intentional and the only way to manage that patient. Consider opportunities to time dose within established patient routines. It's always easier to remember if it ties to something else you do. That's why mealtime and bedtime are so common. You've got patients who begin to sundown in the evening, trying to move as many of their meds into the earlier part of the day will be better. Removing and discarding unnecessary or expired meds prevents confusion. It also prevents a lot of mistakes, getting the wrong med or getting the wrong dose. Like I said, teaming up with pharmacy personnel is really helpful. Many agencies have had great success with medication review and simplification just by teaming up with some pharmacy personnel, whether it's a local pharmacist, whether it's a pharmacy school and their students that are doing it, whether they're volunteering some time with you, or whether you're serving as a rotation for the learning students is another thing you can have. You can work with the patient's individual pharmacy also in the same way, to be able to look at how they're doing review, because they do have that responsibility to keep a review on the patient's meds. All of those things can be very helpful. So enter an agreement with any of these folks, the hospital pharmacy, the school of pharmacy, a health system, whatever you might have. Review and identify alternatives to their medication regimen to reduce the number of meds that may be duplicative, inappropriate, or no longer necessary. Identify substitutes for high-risk drugs for the older patient that provide less risk, or non-pharmaceutical options, and suggestions to streamline and simplify the schedule. Make recommendations to the patient's physician and home health team members. They're very practical kinds of things, and often folks will be very glad of all of this. If we want to improve medication adherence, everyone in healthcare has a significant role in improving adherence. Increase the education about the medication adherence. That captures public attention, increases their understanding, and enhances the motivation to take prescribed medication in the recommended way. The advertisements from pharmaceutical companies that are on TVs, often around evening times or around different news times, use some very nice interactive kind of issues. I think about a number of them that have some older folks and have children with them, and the children are asking, well, why are you having shortness of breath sometimes, or why do you have trouble breathing? Or it's like you when the father or the grandfather or whomever might be reading the story about the three little pigs. There's so many other things. We certainly see a lot of other ads that catch people's attention for their creativity. Only by making the public aware of the role individuals play in management of their own health conditions will we empower people to ask questions about their medicines, fill their prescriptions, follow their treatment schedules, and do what they need to do. So we all have to be part of that. It's too easy to have mistakes made. Use verbal discussion, reinforced with written materials, helps patients to understand their medication condition and their treatment. Clear information in the patient's own language helps to get the correct management of medication administration, the timing, and how long to take the meds. Educate patient in the array of med adherence aids or devices available. There's a tremendous number of dosage reminders and pill boxes and pill reminder programs. Some of them have bells and whistles, and they set an alarm off. Some of them can connect with a phone number if the person hasn't picked up their meds. And then there's the basic ones that are just the plastic boxes that you fill once a week. So we've got all of those and how they could work with the patients and how you can help do that. Even younger patients are more and more using med boxes to help them remember in busy life if they've taken their meds or not. Tailoring the medication regimen to the patient's daily schedule and lifestyle, and certainly instruction in home monitoring activities and record keeping are really important. Just having a checklist, having a calendar, you can mark things off. There's no doubt whether I took my medicine today or not if I look at those issues. So there's lots of things that we can do that are simple that will help. The barriers to medication management. Literature has recorded over 250 barriers to good medication. They're classified here on this table under patient-related, medication-related, provider-related, and health system-related. And you can see the patient ones common for a lot of our patients: forgetfulness, lack of knowledge, or lack of value of therapy, culture, ethnical issues related to medications. We could have financial issues, health literacy, social support groups, or social support issues. Under medication-related, those complex regimens more than anything else. And the side effects when you have multiple medications and a long length of therapy. The provider relations, are we talking? Do we not have good communication skills between the physician, the pharmacist, and the home health folks? Do we have cultural issues about talking about things like medications? That can make a big difference. Emphasizing negative aspects of the medications versus the benefit. Health system-related type of health insurance, type of pharmacy coverage, talking with your pharmacy. There's a whole bunch of things in there. And there's a reference to this whole study in the references as well. Keeping a record of your medications. This would be for the patient, a simple handout that you can give for the patient. List the medicine. Often it's whatever its generic name might be, if that's how they're getting it, what its other name might be. So if they happen to get one filled that way, they'll have both. How are they supposed to take it? What is it used for? Who ordered it? And then anything else, like, for instance, taking it on an empty stomach, or don't take more than 8 tablets in a day, or don't drink alcohol with this particular drug. So providing patients with that current list of medications they can bring to the pharmacy, physician appointments, ER visits, and hospital admissions saves so much difficulty from everybody and gets much better information to the patient as we go along. So there are even more tools and tips as we look at them. Developing processes for easily identifying the addition of new medications, changes in dosage, education provided related to meds throughout the episode of care. How do we assist other clinicians to easily identify if there have been changes? How do we work together to support one another? There's just more and more of those issues. There's a manual or electronic medication profile that can be updated through the care system. Designated location in the record for all clinical staff to record changes in education. That's one tool. Most of your electronic records have that sort of a tool. A flow sheet to document ongoing medication education to the patient, the caregiver. A designated area in the record where all the information about meds is kept. Those tools alone are great. So we have come to the end of our basic presentation, and we do have a couple minutes left, so hopefully we have some time for Eric to pick up, give you some further information about your continuing education and information, and I turn it to him.
Great. Thank you so much, Judy. That was wonderful. That was a lot of great information. So just for clarification, attendees who were on the call will be eligible for 1.5 CE credits. To obtain your credit, look for an email from Capital Nursing Education. You will receive an email between 5 to 7 business days. Be sure to check your spam folder. If you did attend with a group, please provide your attendee list to Capital Nursing Education when you do receive that email. If you don't receive an email between 5 to 7 business days, please be sure to email Capital Nursing directly, capitalnursingeducation@gmail.com. I'd like to encourage folks to join the Shield Healthcare community. If you missed any portion of this webinar, you can capture it on demand. It should be posted by the end of the day today at Shield Healthcare Community. We've got all the community information on our blogs and upcoming webinars, so please check that out. So here's our resources as well. We don't have time for questions because we went an hour and a half, but so far the feedback has been really, really great. Judy, I'd like to thank you so much for the presentation, and I'd like to thank those who attended this webinar. We do have a webinar, upcoming webinar next month in June for activities of daily living. Again, I'd like to thank everybody for attending, and have a great rest of your day. Thank you so much, everyone.
Thank you.